Hello, everyone, and welcome to today's webinar, Timely Diagnosis of Myeloma in Populations with Comorbidities and Health Disparities, Testing Considerations. I'm Christina Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Cebia. To learn more, visit cebia.com. Now, we encourage you to participate today by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. Also, if you experience any technical questions, you can utilize this Q&A box and we will assist you directly. Now, I would like to welcome our esteemed speakers, Dr. Joseph Mikhael, Professor, Translational Genomics Research Institute, City of Hope Cancer Center, Chief Medical Officer, International Myeloma Foundation, and Dr. Christopher Farnsworth, Associate Professor, Pathology and Immunology, Section Head, Clinical Chemistry at Washington University School of Medicine, and Medical Director, Clinical Chemistry and Point of Care Testing, Barnes Jewish Hospital. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Dr. Mikhael, Dr. Farnsworth, it's a pleasure to have you. You may now begin your presentations.
Well, hello, everyone. It's wonderful to be with you today to talk about a particularly important topic to me. My name is Dr. Joseph Mikhael. I'm a professor at the Translational Genomics Research Institute in sunny and hot Phoenix, Arizona. And I also serve as the Chief Medical Officer of the International Myeloma Foundation. So the topic, as we've heard already today, is the timely diagnosis of myeloma in populations with comorbidities and health disparities, with obviously a focus on testing considerations. With respect to my disclosures, I have been a consultant for the companies as listed here. I am not being reimbursed for this talk. So I'm going to focus on, you've seen the objectives for the whole of the program. I'm just going to focus in this talk at the start of this program in a few objectives that I want to cover with you over the next 20 minutes or so as we think together about the importance of this issue. We'll just very quickly review the basics of myeloma. I know many of you are very familiar with it, but just want to bring us all up to speed and then focus a bit on the disparities. I'm going to make the case that myeloma is the most disparate cancer within the African-American community. And as an African-American man, this is personal and professional to me. So I will be sharing with you some of that detail. And then we'll talk about the importance of that timely diagnosis, because so often myeloma is diagnosed late. And then towards the end, and I know Dr. Farnsworth will bring us into more detail regarding this, we'll talk a little bit about the initial, at least, diagnostic algorithm, especially from a primary care standpoint where it tends to begin, and how we move ahead with being able to confirm that diagnosis. So what is myeloma? Of course, you're familiar with the fact that it's a malignancy of the plasma cells in the marrow. So instead of making the appropriate immunoglobulin, it makes the clonal immunoglobulin, or the M monoclonal spike, as we call it, on the serum protein electrophoresis. And of course, it's characterized by that classic CRAB criteria: calcium elevation, renal insufficiency, anemia, and bone disease. And so not a lot has changed in this per se in myeloma, but as we're going to show you in a moment, we've kind of moved from CRAB criteria to so-called what we call the slim CRAB criteria, as we have defined the disease now not only by histology, not only by end organ damage, but actually somewhat in between those two things, which was really a tidal shift in myeloma that happened, in fact, 10 years ago in 2014. I'll come back to that in a moment. So a little bit more about multiple myeloma, that we had about 36,000 cases last year in 2023, and tragically about 13,000 deaths. Based on the SEER database, we know that there's about a 59% 5-year survival, but that it really continues to improve. I was just in my clinic having chat with patients and explained to one of my newly diagnosed patients that the expected survival now, at least in standard risk myeloma, is well over a decade. Although in the vast majority of patients with myeloma really do not know the cause, we know that it tends to be a disease of older individuals with the average age of diagnosis about 69. I'll share with you in a moment how that's different based on race and ethnicity. It is a little bit more common in men than in women, but it is twice as common in those of us of African descent. And that's particularly important. I'll be using two different terms throughout the talk. Sometimes I'll refer to African American when I speak of the sort of genetic underpinnings, and then I may use the word Black when I speak of Black patients as more of a social reflection of the disparity that we'll be discussing. We haven't fully understood the family history component of myeloma, but there is a portion of it, although we do not routinely screen. There is a connection to obesity, although not fully understood. And then there really is a connection, of course, to its precursor conditions we'll be discussing with MGUS, but importantly to certain radiation and other exposures. Our veterans, for example, have been exposed to Agent Orange. I had a patient in my practice who had been a scientist at Chernobyl. I mean, we know that there are rare exposures that can contribute to the risk of multiple myeloma. But from the testing side, of course, we're going to be diving into the importance of the immunoglobulin molecule, and I don't have to educate this crowd as to what this is with both heavy and light chains in the regions that are described here. But of course, this is reflected in the malignant side of myeloma in that we can have myeloma with the majority of patients have an intact immunoglobulin, be it IgG, be it IgA, or typically IgM. Not very common to have IgM myeloma, maybe 1% of cases. We actually do have IgD myeloma as well, inordinately rare, but can occur. And then, of course, based on clonality, be it kappa or lambda. And then almost 20%, and this becomes important in the diagnostic algorithm, almost 20% of patients have light chain only disease, where if we just look for the intact immunoglobulin through serum protein electrophoresis, that's not going to be sufficient. And then there are a group of patients, and this number is shrinking as our sensitivity to detect light chains is getting better, but there are still some patients who are considered non-secretory because we can't detect a monoclonal protein at all. And that's more challenging because typically by the time those patients are diagnosed, there is significant advanced organ damage. By virtue of subtype, a little over half of patients are of the IgG type, about 25% to IgA, as I've mentioned, and less commonly IgD and IgM, as noted before. So you're, I'm sure, familiar with the concept of the serum protein electrophoresis. Many of you are very much involved with this, even more than I would be. And here's a beautiful reflection of a serum protein electrophoresis that is normal. But now, of course, here we have an M spike, an IgG lambda type, hence the word spike that we use when we look at it. But of course, we have to recognize that we don't just look for the M spike, we look for the light chains as well, which is an important consideration in the whole of the talk today, because in my experience, I've been a myeloma doctor for over 20 years, that so often patients with light chain only disease often are diagnosed later because people haven't been looking for it. And of course, you know, myeloma is a unique cancer because it's not just defined by the pathology or the histology of the disease. We think of it as a disease of damage to an organ. And we used to wait until it was true CRAB criteria. You don't have myeloma until you have CRAB. And that was a reasonable approach because there were so many patients who just had a monoclonal gammopathy, so they had the abnormal protein but never organ damage. In fact, up to 5% of people in the world, we are exploring this. We've just screened 90,000 people in Iceland, obviously a country where more people have had their whole genome sequenced than anyone else to understand this better and the genetic underpinnings of the disease. But we know that up to 5% of people over the age of 40 have a monoclonal gammopathy. So the vast majority will not develop myeloma, hence the phrase monoclonal gammopathy of undetermined significance. But there are people who ultimately, of course, will. And so 10 years ago, as I noted, we redefined myeloma and clarified the notion of smoldering myeloma and active myeloma. So we used to say you had to have CRAB criteria, but now we've added 3 other criteria to this that clarifies the difference between MGUS, smoldering myeloma, and active myeloma. And what differentiates these, of course, is going to be between MGUS and smoldering myeloma, the potential of developing myeloma, and indeed when we intervene, because we typically do not intervene in MGUS, and we typically do not intervene in general in smoldering myeloma, although within that spectrum of smoldering, when patients are at the highest risk end, we may consider intervening at that point. And so now we think of this acronym a little bit like SLIM CRAB, as I've called. That was my contribution to the myeloma community. I came up with the acronym SLIM. I can drop the mic now and give up my career. But the SLIM, or the SLI, stood for S 60% plasma cells. So if someone does a bone marrow and they have more than 60% plasma cells, that is active myeloma, even in the absence of CRAB. The LI stands for the light chain ratio, or at least the involved over the uninvolved light chains. If it's greater than 100, so kappa over lambda or lambda over kappa, if it's greater than 100, then that's active disease. And we know the kidneys are going to be affected soon and we should treat. And then if there is greater than one focal lesion in the marrow on MRI, hence the M, and that becomes now the 7 myeloma defining events, CRAB plus the 60% plasma cells, involved over uninvolved light chains of 100, of greater than 100, and more than one focal lesion on MRI. And of course, you know that it isn't just the CRAB criteria. There are other things we see our patients present with: neurological conditions, infections, constitutional symptoms. It can be quite extensive. But the diagnosis is typically challenging because the 3 most prominent features that trigger us to think about myeloma are fatigue, bone pain, and anemia. And of course, these are incredibly general things that can reflect so many different other issues. And that's why, unfortunately, as we see here from our colleagues in Europe, that the average myeloma patient actually is seen 3 times by their primary care provider with signs and symptoms consistent with myeloma before the diagnosis is made. And now what I'm going to focus in on is why we see difference in this by race and ethnicity, because of lots of reasons, that there is a delayed diagnosis and then reduced access to therapies, as I'll describe in a moment. That's why it's so important that we do seminars like this to talk about testing considerations, both to think of the right test and then to order, to think of doing the testing, then to order the correct testing so that we can reduce that. I'm going to compress my long disparities talk literally into one slide. And so when we think specifically about African Americans, although there are significant disparities in other populations, such as Latino American patients who live geographically far away from cancer centers. But the top 7 key points here are: there's a longer time to diagnosis. I mentioned already, it takes 3 visits for the average patient. That's on average 3 to 6 months longer in African American patients. The average age of diagnosis is younger by about 5 years. And that skews our thinking, because we get taught in med school that myeloma is a disease of very old people. We often have younger patients who are African American. I already mentioned that it's twice as common. In terms of access of therapies, if I would argue that there are 4 things that have changed the course of myeloma over the last many years, it has been the 4 T's, as I call it: transplants, triplets or 3 drug combinations, clinical trials, and CAR T-cell therapy most recently. All 4 of them, sadly, we have seen reduced access within the African American community. Then there's biology. Some might say, oh, well, maybe there's an inferior outcome in African Americans because they have more aggressive biology. In fact, the opposite is true. An African American patient diagnosed with myeloma is less likely to have high-risk features like 17p deletion and more likely to have lower risk features like the translocation 1114. Sadly, the worst of the list here is number 6, that survival outcomes are half. So meaning a Black man or a Black woman diagnosed today with myeloma is expected to live half as long as a same-aged white man or woman. Totally unacceptable. And to add to it, number 7 is that we know from studies like within the VA system that when the same diagnostic and therapeutic algorithm is provided to all, because theoretically, no matter what your race or ethnicity is, you get the same access within the VA system. African American patients do just as well, if not better. So there's clearly an opportunity here to reduce that disparity. And of course, disparity, to make it very clear, I like the CDC definition of it. This is a preventable difference that is disallowing people to achieve their optimal health. Those are, to me, the key words here. And so when we seek health equity, we're again seeking their highest level of health, not just some basic level, but the highest level for that individual. Now, I could give you a long talk on what drives the disparities of health in general in our society that have a lot to do with the social determinants of health, economic stability, education, food, the tragedy of food deserts in our country. So many things I can get into. I'm not going to get into that side of it, but I'm going to make it specific to multiple myeloma. that there are those more general systemic issues, systemic racism, the way the healthcare system is designed, those social determinants of health that I indicated, and lack of trust within the medical system. I would say that those are the sad four pillars that we see affect the health primarily of African Americans, but other populations within the country. Now, getting it into more specific of myeloma, we see that the biology of the disease and concomitant comorbidities can definitely influence. And if you've been napping and you want to just like wake up for 30 seconds, wake up for this bit, because one of the reasons why I think we see a delayed diagnosis, which I'll come to in number 6, is these concomitant comorbidities and specifically diabetes. I'll show you more in a moment, but so many of the same signs and symptoms we see of myeloma, we see in diabetes. And often that overlap, people get told, oh, you're anemia, you're renal insufficiency, you're proteinuria, your neuropathy, that's all from your diabetes, when in fact they're brewing multiple myeloma. So it's very important for us to recognize that there's more to it. That delayed diagnosis I've commented is very important. Access to those 4 basic things, as I've mentioned. And then, of course, on us as providers, we often lack the cultural sensitivity and the optimal communication. We don't have enough of us, right? So if African Americans, for example, if we constitute 14% of the population, we're 6% of physicians and less than 3% of oncologists. So we have to do something there, just not to just match a number, but to ensure that everybody is being treated. So at the IMF, and I don't want to be a commercial, so I really only have a couple of slides here, but we've created a program called the Empower program, which is designed to improve the short and long-term outcomes of African Americans with myeloma with a 3-pronged approach, of which today's seminar is part of that second prong. The first prong is engagement. Let's engage the community. We go to churches, fraternities, sororities, community centers, anywhere possible. Social media, you'll see in a moment people that we've worked with to try and engage the community so that they can know about myeloma and understand it. We educate primary care providers and those involved in the testing of myeloma to make sure that they think about myeloma and that they order the right tests. And then lastly, we want to enhance the care of the myeloma patient by ensuring that they have access to equitable and optimal care. So I've worked with people like Ice-T, for example, who's been a great help to us. He did a video for us and we had it on the NASDAQ in New York City for the first week of Black History Month this year, so people could understand it. I've had the privilege of working in churches, as I've mentioned. We did a Juneteenth program at Abyssinian Church in Harlem, raising awareness within the community, having them understand how myeloma preferentially affects this community, sadly, both in incidence and in mortality, and how we can overcome that. We've created a program where I work with medical students, many from historical Black colleges and universities, to be paired with a myeloma doctor to do a project in health disparities. We all gathered at the National Medical Association where they can present their project as posters so that they can be sensitized to health disparities, but also we build a workforce that is committed to myeloma and reducing those disparities. And then, of course, as I've mentioned, we educate within the primary care world and have tried to do our very best to do that. And that's important because about 2/3 of individuals who are diagnosed with myeloma come through the primary care path. Lots of other physicians are involved and healthcare teams are involved in the emergency room, neurology, rheumatology, nephrology, cardiology. So we want to get the word out more broadly, because when patients do have a lengthier delay in that diagnosis, it affects their organs. We see greater infections, greater anemia, greater neurological conditions. It's unequivocal that it's worse for these patients going forward if their diagnosis is delayed. So there's no perfect algorithm. We're not quite at a screening stage yet, and that's a whole separate discussion. I think we will, much like breast cancer and colon cancer, eventually figure out in whom we should screen for myeloma. But for now, when patients have persistent bone or back pain, if there has been an unexplained fracture, if there are incidental findings that are associated with myeloma that include anemia, renal dysfunction, hypercalcemia, bony lesions detected on an x-ray, neuropathy, or osteopenia that is out of keeping with their gender and age, then that should trigger this pathway of thinking. And as I mentioned, someday I do think we will go towards screening. So what do we do in terms of testing? And again, start very basic. We start with the CBC, of course, because that is primarily looking for anemia, but we can see pancytopenia in these patients. We obviously have to look at their kidney function and understand what their creatinine clearance is. And then we look specifically at basic protein, starting with the total protein, which often is a trigger. I just saw a patient recently who myeloma was diagnosed as what I call an incidentaloma because they had total protein checked for insurance purposes. And then, of course, we want to know what the beta-2 microglobulin is, what the LDH is. These point us towards that. And then the crowning glory here is ensuring that we look very meticulously for the monoclonal proteins, specifically with a serum protein electrophoresis and a reflex immunofixation, which most labs, of course, will have, and a serum-free light chain assay that looks for the light chains, both kappa and lambda, and obviously calculates a ratio. And indeed, urine testing, at least I would argue as if the clinical scenario is consistent with myeloma, that we actually obtain a 24-hour urine to look for it. And then, of course, as you know, with these tests, we're looking for both the heavy chain and the light chain, because we know historically that if we don't do both of the heavy chain and light chain testing together, we're going to miss a lot of patients. And we get nearly to 100% sensitivity for both myeloma and its cousin disease, AL amyloidosis, when we order both of those tests. And so sadly, that's not done. I know this is a relatively old study now, but we've sadly confirmed over and over again, it's very rare for people when suspecting myeloma to order a full test. I'm doing a study, for example, at Grady Hospital in Atlanta, where we have kind of a myeloma button. So instead of people having to order these different things, if they suspect myeloma, it triggers the whole testing algorithm and is able to track it and provide the results to the myeloma clinic if a positive result is detected. And so that's why it's so important that we look for both heavy chains and light chains. And this, of course, even comes from the CAP guidelines, right? The CAP guidelines that you can see here, the very number one, clinical care providers should order both SPEP and serum-free light chain for the initial detection of M protein in all patients suspected with a monoclonal gammopathy. So important to do. So just as I get towards the end here, just a couple of things to help make that distinction, and why sometimes we miss out a little bit on this testing is that when we think of what myeloma looks like, it's, as I mentioned, not just the CRAB criteria. We can see a lot of these different things here that patients experience with bone pain, with due to cytopenias, due to hypercalcemia, due to kidney disease and neurological symptoms. But interestingly, look how many of them overlap with diabetes here in red. So it is important for us to recognize, in particular, we're also about to launch a study where we're looking at diabetes clinics and screening more meticulously for myeloma, because I do think we are missing a lot of these cases because of it. So narrowing it down to the end, getting to the basics, the CBC, the creatinine, the calcium, the serum protein electrophoresis, serum-free light chain assay. If these 5 things are done, obviously there's corroborating things to this, but when these 5 things are done, it points us in that direction. Last comment about imaging is that we now have really gone beyond. I just saw a patient whose screening test was a skeletal survey, and those days are gone. We need to use advanced imaging now, typically a CT scan, an MRI, or even a PET scan to detect myeloma when it is suspected. And I like to show this slide because I really do think that this is a system-wide phenomenon. It isn't just myeloma geeks and nerds like me that want to have this pathway improved. It really involves primary care, our colleagues in the lab, many of those specialties that I described, and a concerted effort for us to work together to make that right pathway. If you want to learn a little bit more, we relatively recently published this kind of a summary paper on the primary care side of it, at least, of how to promote an earlier diagnosis. So in conclusion, myeloma is typically diagnosed, sadly, late in the disease course. It's twice as common in African Americans with a longer delay because of lots of reasons, as we've discussed, including those overlapping comorbidities like diabetes. The several general signs and symptoms can present and have to be considered, especially in those higher risk populations. And that diagnostic algorithm, as I briefly outlined, requires those basics, the CBC, the biochemistry, but both the serum protein electrophoresis and the light chain assay. And it's so important that we have a good communication together so that we can capture this disease. And we believe, and we're starting to demonstrate, that when we do intervene earlier, obviously there's that spectrum, as I shared, from MGUS to active myeloma, but when we intervene earlier, patients will do better. And we have a lot to intervene with. I know this is an overwhelming slide, but it's my favorite one because I love to show the progress we've made in myeloma. I've been a myeloma doctor for over 20 years. And when I started, this slide had 1 or 2 words on it. Now it's amazing how many drugs we have and strategies that we have to be able to conquer this disease. Feel free to learn more about what we're trying to do in advancing healthcare equity at the International Myeloma Foundation at myeloma.org. And please always feel free to reach out to me. It's such a pleasure to be a part of the myeloma community and try and serve our patients in this way, and indeed to present at a wonderful webinar like this. And I'm delighted to do it and look forward to hearing Dr. Farnsworth shortly. Thank you so much for your attention.
Well, thank you so much for that lovely presentation, Dr. Mikhael. And now we're going to pivot a little bit and talk a little bit about the laboratory considerations for myeloma testing. Again, my name is Christopher Farnsworth, and I'm an associate professor of pathology and immunology at Washington University in St. Louis. I do have the following conflicts of interest. The only relevant conflicts to this particular discussion, though, is that I have done research for 2 of the companies that we'll be discussing today, Sevia and The Binding Site. By the end of this talk, you should be able to discuss the limitations of serum-free light chain assays. You should be able to contrast the specificity of free light chain assays in a healthy versus a comorbid or sick population, and then interpret the effect of serum-free light chain assays and reference intervals on patient care. And just to quickly recap us from Dr. Mikhael's talk, multiple myeloma symptoms can really mimic other comorbidities, and there's not really a general screening mechanism for myeloma in the population. So diagnosis is often made with a differential from other potential conditions or comorbidities that we're going to talk about in a few moments. And there's also multiple serum-free light chains assays available on the market, which do provide some challenges when we think about diagnostics. So before we get into that, I do want to discuss the incidence rate and mortality in Black patients for myeloma relative to white patients. So this is data from cancer.gov, and you can see the purple triangles here are white patients, and the green triangles are Black patients. Your x-axis is the years of diagnosis, and the y-axis is the rate per 100,000. What you can see here very clearly is that the incidence of multiple myeloma in Black patients is clearly increasing, whereas white patients are about half the rate or half the incidence, and they're also fairly stagnated. And the same is true with mortality rates. So thankfully, they're decreasing across all populations in the US, but we can see here very clearly the incidence of mortality, or the rate of mortality, is about twice as high in Black patients relative to white patients. So clearly there's a health disparity here. And this is something that really it hits close to home for me, being from St. Louis, Missouri. I live in an area that perhaps has the greatest disparity between wealth and poverty in the country. So we're very close to our hospital is a road named Delmar Boulevard, which you can see on the picture on the left. There's much lower home values in the section shaded red, $78,000, lower income, very few with bachelor's degrees, and mostly Black or African American. And then south of that line in blue, about 3 times as higher home values, twice the income, almost 2/3 of the population have bachelor's degrees, and there's 70% white population. So this area has been highlighted by the Washington Post and the BBC as this really interesting dividing line of health disparities and disparities in general. So to put it bluntly, St. Louis is one of the most racially segregated areas in the country. And really what I want to spend my time talking about is the potential impact of race and some of these comorbidities on diagnosis of myeloma. So to start, it seems like an interesting place to start. But what we're going to start with that is actually talk about the guidelines. And the guidelines are actually assay agnostic with regards to what you should use when testing free light chains. So these are from the International Myeloma Working Group, or IMWG. And they say for diagnosis, the involved to uninvolved serum-free light chain ratio should be greater than 100. And then they go on in a bullet point to specify that this is using the free light assay. And where they got this from was from a study on 586 patients with smoldering myeloma, and they tested free light chains on the BN2 nephelometer, and they used a ratio of 100 for risk. And what you can see here on the x-axis is time to progression in myeloma, and the y-axis is the proportion or percent of patients progressing to myeloma. And you can see that patients at baseline that had a free light chain ratio greater than 100, about 98% within 5 to 6 years went on to progress to myeloma, whereas only half of the group with free light chains less than 100 or less than a ratio of 100. So the takeaway here is that 100 is associated with a higher likelihood of risk to progression to myeloma in these patients. As laboratorians, though, it's likely that the use of a consensus-guided threshold makes you uneasy, as it implies that this cutoff of 100 performs the same across every single assay that's on the market. So this actually gets at that question. This is actually a study that we published in 2023 from my research lab, looking at the free light chain assay on the cobas compared to the free light chain assay on the Optolite. So the same exact juice, but on two separate instruments. And what you see here, the dotted line would be the line of unity, and this dark line is what we actually saw for the regression line. So in about 350 or so patients, we saw that there was actually a pretty significant slope and intercept. And if you look at the plot on the right, labeled B, you can see the capital lambda ratio on the cobas versus the Optolite. And by and large, they did correlate quite well. But there were actually some patients where there were significant differences, where they were below 100 before and above after. And in some cases, they were quite a bit lower, as low as 3 or 4, but went as high as 10 or 20 or 30 after. So the impact of this is actually so high at our institution that there's actually two separate labs, one that uses one instrument and one that uses another. We actually trend them on separate lines because we don't think it's appropriate to use them, to exchange them. So can we use this serum free light chain ratio of 100 with any other assay? So this is actually a study that was performed by the Mayo Clinic in 2022. They had 284 residual specimens in patients with smoldering myeloma, and they tested them on the free light assay as well as the CBF free light chain assay. Shown here is a table. On the left are the CBA results, on the right are the free light results. You can see that there were 101 patients that had a ratio greater than 20 on the CBA and 106 on the free light. And for a ratio, again, that ratio of 100, which is the diagnostic ratio, 26 on the CBA and 30 on the free light. So very similar with regards to numbers. So if we look at the performance, the sensitivity for the free light was 25.7 and 19.4 for the CBA, and the specificity was 90.8 and 92.3 for the CBA. So what can we kind of take home from this? Well, while the assays can't be used interchangeably, the study does seem to imply that thresholds of 100 for risk may be appropriate across multiple assays. Now, what about the others? What else do the guidelines say with regards to assay? Interestingly, they also make a claim for the ratio or the normal reference interval, and they say that for serum-free light chains, the capital lambda ratio should be 0.26 to 1.65. And we have the same problem here as before. We're using a reference interval that's derived from one assay and saying this is what's normal for all assays. So where did this come from? Well, this study was published in 2002 from 127 healthy donors, another 155 samples from frozen donors. And the primary demographic they had was age. You can see here for the kappa on the left and the lambda on the right, the concentrations obtained in these healthy samples. These patients had no history of myeloma, normal protein electrophoresis. You can see where they fell. So the authors took this data and they did two things. They calculated a central 95th percentile reference interval like we normally would in a laboratory. You can see that on the left side, and from that they also came up with a reference interval for the kappa lambda ratio of 0.3 to 1.2, but they also claimed a diagnostic range. So the diagnostic range was 0.26 to 1.65, and that included 100% of the reference population, so all the points on the previous plot. So this is actually what the IMWG is using for their normal range in patients. And how does this perform? So on the left is the reference interval, on the right is the diagnostic range. You can see they both have very high sensitivity, specificity, positive and negative predictive value, and accuracy. And this is compared to a cohort of 25 patients with hypergammaglobulinemia and another 66 seraphim patients with plasma cell dyscrasias. So really the take home here is that in this study, this diagnostic range performed quite well, and it's what the IMWG adopted. So how are these reference intervals currently used? Well, there's a few different ways. The first is as a risk factor for progression from plasma cell dyscrasias in patients with monoclonal gammopathy of unknown significance, We're going to talk about this study in a moment. It's also used in multiple myeloma to designate stringent complete response after therapy. So have we treated that patient down to response? And then finally, it's used in the definition of serum free light chain monoclonal gammopathy of unknown significance or uncertain significance, also known as LC-MGUS or MUGUS. And this is defined as just an isolated abnormal free light chain ratio without evidence of a heavy chain in that particular patient. So this was one of the examples of how the reference interval or that diagnostic range is used. This was a study in 1,384 patients with MUGUS. Baseline serum samples were obtained within 30 days of diagnosis and were available in about 1,100 of those patients. And you can see they followed these patients for 15 to 30 years. And they just asked if patients had a normal free light chain or an abnormal free light chain ratio, so outside of those IMWG specific thresholds, what was the probability that they progressed to multiple myeloma? You can see here in the darker line, the patients with an abnormal free light chain ratio had a higher probability of progressing to myeloma, almost 45 to 50%, compared to those that did not progress, or compared to those with a normal free light chain ratio, which was more than half or less than half. You can actually think about this with regards to the relative risk in terms of the concentration. So again, this is all baseline free light chain ratio. You can see that in the middle, the reference range, the diagnostic range, I had the lowest risk of progression. But as you go much higher or much lower in that range, the relative risk increased. So the take-home point is that patients with MGUS, the reference interval seems to be very important. However, the current reference intervals do have some issues. Here's one example. This is the ISTOP multiple myeloma study in thousands of patients without myeloma. What we're showing here is the estimated glomerular filtration rate, or eGFR, which tells you about kidney function. And then on the y-axis is the free kappa, free lambda, and free light chain ratio, respectively. So eGFR of 60 or greater is considered normal. And you can see as these patients' renal function decreases, so as it goes from 60 to less than 60, the patient's free kappa, free lambda, and free light chain ratio also increases. So this implies that the reference intervals are actually impacted by renal function. And we're going to talk about this more in a few moments. This is also another study, though, that's very interesting. This is 8 years of data from the Mayo Clinic. On the upper x-axis, the arrows pointing down demonstrate lot changes when they've been using their assay, which happens to be the free light chain assay. And you can see the circles where the manufacturers have actually done, have had to correct the lots because of assay drift. As you look a little bit further below, the line of fit is shown with a confidence interval here. And basically what you're seeing here in this dark gray with the black circles, those are the patients with a ratio greater than 1.66. So in healthy patients, they've seen an increase in about 30-ish% to like 42%, 35 to 42%, being above this ratio. And then on the bottom, the diamonds, you can see the proportion of patients with a low free light chain ratio has actually decreased. So there's some assay drift that has gone on with this particular assay, which again, this has not been addressed at all in the IMWG guidelines. And then of course, how does it perform across multiple, across different assays? So we have this assay agnostic reference interval that was built from one assay. How does it work in others? Well, turns out this is actually a slightly different study. We're not using the free light chain reference interval here. We're using one developed from CBIA, but what they showed is that when they used their assay-specific reference interval, they had a similar sensitivity as the IMWG reference interval for myeloma, as well as a similar sensitivity for free light or for light chain amyloidosis. So really, they perform fairly well, but again, this is a slightly different reference interval for CBIA. But this kind of had us thinking, okay, so we have these guideline-endorsed reference intervals, but what is the clinical specificity of these serum free light chain assays in racially diverse patient populations with comorbidities? And that's really where we're going to spend most of the rest of our time. So the study design was fairly simple. We took 194 patients that did not have myeloma or amyloidosis, so no previous diagnosis mentioned anywhere in the electronic medical record. All patients that were collected at my hospital here at Barnes Jewish Hospital in St. Louis. We then tested these samples on the binding site assay using the Siemens BN2, which is the predicate or the first method used for this reference interval. And then we also performed CBA free light chain by ELISA. We went on to assess total protein, serum protein electrophoresis, plasma creatinine, and mass fix. And basically what we did is we excluded anyone with any previous diagnosis of plasma cell dyscrasia, a monoclonal peak by serum protein electrophoresis, or monoclonal peak by mass fix. And for those not familiar with the mass fix method, it's very similar to immunofixation in terms of detecting free light chains or heavy chains that are single clones. It just has increased analytical sensitivity. We then included a very specific study population. So we only recruited patients that had one of the following: elevated immunoglobulins, kidney disease, peripheral neuropathy, arthritis, inflammatory disease, fatigue, back pain, anemia, other neoplasms, joint disorders, musculoskeletal disorders, malaise, and myalgia. And why did we do this? We really wanted patients that presented similarly to patients with multiple myeloma. And the problem with any reference population for a specificity study is that none of your patients are sick. So your specificity is going to look a lot better than when you implement an assay in real sick patient populations. So we really only included patients that had one of these diseases in our cohort. So how did the reference intervals perform from these various manufacturers? Well, first you're looking at the free light, and you can see how we've broken down our patient cohorts from left to right: kidney disease, polyclonal stim, anemia, myalgias, malaise, bone issues, and other cancers. You can see that quite a few patients on the free light assay actually are above the reference interval for kappa, which is denoted here in the gray bars. We can see actually almost 70% are above. And it's actually a similar story for the CBA assay. So almost 121 patients fall above this reference interval using the CBA assay. What about Lambda? So the same story is actually there in Lambda, just reduced. So interestingly, with the free light assay anyway, only 64 patients were above the reference interval and 2 below, so 36% of patients. And again, kidney disease being the most prevalent. And then when we look at the CBA assay, it's actually more similar to the kappa. Almost 83% of patients were above the reference interval in this case. So very interesting. Really, really high results for both kappa and lambda, more so from the CBA than the free light. What does this mean with regards to the ratio? Because that's what our providers are really mostly hanging their hats on. And so if we look at the ratio, this is again looking at the free light. The gray lines here are again the IMWG range, which included, remember in that Mayo study, 100% of healthy subjects. Here, only 70% or 31% were above the reference interval, and 0 were below the reference interval. So these various disease states actually drove a considerable number of people outside of the reference interval, particularly those with kidney disease and polyclonal stimulation. We can contrast that to the free light, where it was actually far more balanced. So we had 8 patients that were above the reference interval and 14 patients that were below the reference interval. And it still does seem to be disease specific. Kidney disease seems to be the highest, but the vast majority fell within the manufacturer's claim. So the take home here really is that the assay used in the reference interval does impact the specificity of the assay. And you can actually see that shift fairly clearly here. You can see that this is just plotting the free light results relative to the CBA results, and they're very much shifted down and to the right, with the black dotted line or dashed line being the line of unity. Really, the results are skewed higher for the kappa lambda ratio on the free light assay. You can see in the far right middle set of boxes, the proportion of patients that were elevated by free light that were normal by CBA was really quite a bit higher. Nonetheless, let's look at the potential impacts on patients and what happened to the actual patients, or what it would have looked like for them. So these are patients based on renal function. We've split these out. So on the left plot is patients with an eGFR at 60 or greater. And on the right are patients with impaired renal function less than 60. And you can see here again that patients with impaired renal function had quite a bit higher free light kappa to lambda ratios relative to the normal, with almost 50% of patients with impaired renal function being above the manufacturer reference interval. And this is the data for the CBA-based assay. You can see here that there's a few patients that were normal that were outside of the reference interval, and a few patients with impaired renal function that were outside of the reference interval, but no statistical differences. So they're certainly higher in patients with impaired renal function, but still fell within the manufacturer reference interval. And what's really interesting is when you look at this by race. So you can see here, white patients, Black patients, and other. So these are all patients that self-identified in our electronic medical record. And you can see that similar story to renal function. Almost 50% of Black patients are elevated by the free light assay, but not white patients. In contrast, again, if we look at the CVA assay, almost a similar proportion of patients outside of the reference interval. So if we take a step back and think about this again from a patient perspective, there does seem to be some impact on comorbidities and on race with regards to how the assay is functioning, but how they're falling within the reference intervals. So if we think about the primary study question, what is the clinical specificity of serum free light chain assays in racially diverse populations with comorbidities? On the CVA assay, we found the specificity of 87.5%. And on the free light assay, we saw a specificity of 68.7%. So those confidence intervals shown on the right do not overlap. So these results really imply that reference interval that you use and the assay that you use will really impact the specificity in a diverse cohort of patients. So there's really major take homes, I think, from this. One, multiple comorbid conditions clearly impact the serum free light chain and ratio, regardless of the assay used. But the frequency with which they're outside the manufacturer reference interval are going to be assay dependent. And really, when we bring these assays to market, we really and bring them into our laboratories, it's crucial that we consider the specificity of the assay, not just in healthy cohorts, but in patients that they're going to be used in real time and who we're testing them on, because these do impact potentially further workups on patients and diagnoses, and it's not necessarily benign. So I do want to point out that this work isn't happening in a vacuum. Here's a study that was actually also performed at my institution at Washington University by Vahid Azimi and Mark Zeidman. They took 131 Black patients and 164 non-Black patients, all retrospective data points and specimens from our laboratory that were negative with serum protein electrophoresis and immunofixation. And they had serum creatinine within 7 days. And what they did here is they plotted the eGFR on the x-axis and the serum free light chain ratio on the y. So very similar to the data I showed. But what they're showing here is that the X's are patients that identify as Black. The circles are patients that identify as white. And you can see that the patients that are Black tend to have a serum free light chain ratio that is higher, that is independent of the eGFR. So in fact, what the author stated is the serum free light chain ratio is 0.41 units higher in Black patients compared to non-Black patients with comparable renal function. And that Black patients were 5 times higher odds for increased serum free light chain ratio. So clearly there is a disparity with regards to how these assays are working. So one could argue perhaps that this is an important finding. Maybe Black patients have higher likelihood of progression to myeloma when they only have free light chain MGUS. And I'm not sure if that's true. Now, there hasn't been a study that specifically addressed that. However, this study looked at the proportion of patients that progress to myeloma if they have light chain MGUS. This is, or at least the probability of survival. So on the x-axis again here is the follow-up time. On the y-axis is overall survival. This was almost 5,000 patients, of which 75 had isolated elevated light chains and 4,700 were used as controls. And you can see here that there's no difference in mortality in these patients. So it's about 20% regardless of the group. And what's interesting, in these patients that had light chain monoclonal gammopathies or had elevated free light chains, you can see that 31 had actually sequential measurements. And of those, more than half normalized at follow-up visits. So it really was just an isolated finding. So I think the take home here is that it's really important perhaps that we don't overcall light chain MGUS, particularly in patients with comorbidities or Black patients. I just want to point out quickly one other study that's very important in the literature and what some groups have tried to do to address this. So this was the iStop myeloma study that I mentioned earlier. And really their goal was to try to establish renal reference intervals based on a patient's estimated glomerular filtration rate. So what they did is they tested patients within Iceland, almost 80,000 participants, and they screened them for serum free light chain and protein electrophoresis and then measured their eGFR. And this is the central 99.5 percentile reference interval based on that study data. So you can see that essentially for kappa and lambda, it goes up as the EGFR goes down for each of those. And then similarly, the free light chain ratio, which again, the original reference interval high end was 1.65. For patients with modestly impaired kidney function, it goes all the way up to 2.6 and even as high as 3.3 in patients with severely impaired. So this is an approach that people are taking. I think the limitation here is that this was done in Iceland, which is less than 1% Black population. So it doesn't really address the potential disparity there. Also, trying to operationalize this in electronic medical records could be very difficult. So, but it is something that people are thinking about, and perhaps another approach that we in the laboratory community should consider. So what is the take-home points that I really think you should get across? Really, further studies are needed in diverse patient populations. There's a few that are emerging, but we need more. We need more specificity studies. We need more sensitivity studies, particularly for some of our rule-in criteria. Laboratories need to carefully consider their reference intervals and the assays they deploy for free light chains, and that multiple comorbid conditions can really impact the serum free light chain ratio in an assay-dependent manner, and that there's certainly differences between manufacturers with regards to both assay performance, but also reference interval in various patient populations and in patients with comorbid conditions. So with that, I'd like to thank you all for the opportunity to present this work, and the collaborators, particularly Maria Wilrich at Mayo, that was my co-investigator on this study, as well as my research team, shown to the right, and all the Barnes-Jewish Hospital and Washington University individuals that helped with this. And thank you so much. I think we'll now have a little bit of time for questions.
Dr. Farnsworth, Dr. Mikhael, thank you so much for your informative presentations. We will now begin the live Q&A portion of our webinar. Now, we already have lots of questions that have already come in, but if you haven't already submitted them, please do so now. Just type them into the Ask a Question box, click Submit, and again, we will answer as many of your questions as we have time for. So since we have so many, I'm just going to dive in. And Dr. Mikhael, let's go ahead and start with you with this one. What tests are needed to reliably detect M proteins in any population? And are you suggesting we should screen for myeloma in specific populations more frequently?
So great question. Thank you for that. And really captures the essence of what we're trying to get to and what I was covering in my lecture. So to detect that monoclonal protein, the key message here is that the serum protein electrophoresis by itself is not sufficient. It'll capture up to about 80% of patients with a plasma cell disorder, but we also have to do the serum free light chain measurement along with it. So those two are really together what we're going to need to detect the monoclonal protein. When we do the serum protein electrophoresis, if there's an abnormality, the lab will have typically a reflex, I know Chris can comment on this as well, to do the immunofixation so we can isolate the type. But in terms of trying to detect the disease in someone with suspected myeloma, those are the two key tests that we're going to do, which is, of course, usually accompanied, as I said in my lecture, with the CBC and the biochemistry when it is suspected. Now, the second half of the question here is brilliant because the point is, do we want to look more frequently or do we want to look more meticulously in patients who are at higher risk? So as yet, we don't have formal screening guidelines for us to screen patients. I do think it's coming in the future, in particular the high-risk populations, as we've mentioned, African-American patients, those at high risk for other reasons. But in the interim, if someone is suspicious of myeloma for whatever cause, we commented that the common signs and symptoms tend to be very general, like fatigue, pain, and anemia. But nonetheless, when that is thought of, someone should be testing with that serum protein electrophoresis and serum free light chain assay. It's important to look for both of them. So we're not yet recommending that we screen on a regular basis, but at any point when that suspicion of myeloma comes up, those tests should be invoked.
Very good. Thank you, Dr. Mikhael. And Dr. Farnsworth, let's come over to you for this next question. What would the impact be for patients and clinicians if the SFLC were falsely positive?
Oh, that's a great question. So, we don't often think about what are the potential ramifications of a false positive result. And I think they're actually potentially quite severe in some cases. There was a previous chemist at my institution who used to say that the best way to commit the perfect murder was to have somebody come to the hospital and then start performing lab testing, because eventually you're going to find something that's falsely elevated and you're going to act on it. And I think that's the potential risk with the serum-free light chain assay as well, or in any assay for that matter, is that if you get an abnormal result, it oftentimes is going to prompt a clinician to work that patient up. Sometimes it might be mild. For example, it might refer them to a hematologist or an oncologist. But sometimes it could be more severe. It could lead to further bone marrow biopsy or further workup. So I do think that there is a concern for false positives from both a patient and provider perspective. For a patient, unnecessary resources, more time trying to figure out what's going on. And then if you're diagnosed with something like light chain MGUS, there's that potential stigma of, am I going to develop into something different? Which I talked about in my session, that at this time, it doesn't seem like those patients are more likely to have worse outcomes with regards to mortality. But there's still maybe that concern. I have something wrong with me. So I think it's important that we get this right with regards to saying if somebody truly has disease or not based on the serum-free light chain assay.
Chris, can I add a comment to that if I can? Just to, in particular for the clinicians involved who are ordering it, there are those pitfalls, right? If someone has renal insufficiency to begin with, we know that the ranges are going to be different. In fact, we've just, as you know, recently published on this based on our large Iceland study. So I see this a lot in clinical practice, that someone, maybe on dialysis or has renal failure for other reasons, orders it, and we just have to be cognizant that if I can put it this way, the confidence interval on those levels of the light chains can be a bit broader in a patient with renal insufficiency. So that's where sometimes I've seen, if you will, a false positive or maybe an over interpretation of a slightly abnormal result in those patients.
Yeah, and it probably goes both ways too, right? Potentially in renal patients where you could perhaps underinterpret. You're not expecting to see, you see a large free light chain ratio and potentially attribute it to a renal disease when in fact maybe there's true disease going on. Would you say that's potentially true as well?
Yeah, absolutely. No, you hit the nail on the head. They're just trying to catch that balance in between. But I'm thinking more of when, the ratio is barely off, like it's 3 or 4, as opposed to, when it becomes 10 and higher, where it's just so overtly abnormal. But no, I appreciate you making the comment.
Thank you, gentlemen. So I'm fielding a lot of questions here about urine testing. Dr. Mikhael, what are your feelings about urine testing? Is it still necessary? It seems more like a specific biomarker. So can free light chain testing completely replace urine for amyloid testing, for example?
Well, I can't help but quote a paper that I wrote about 10 years ago, which I submitted with fear and trepidation to the editor, because it was an editorial about a French study that had compared serum and urine testing. Suffice to say, the title of my editorial was P No More. Now, it was a little bit obviously meant to be humorous, but I think the simple way I approached urine is as follows. It really isn't an optimal screening method. The vast majority of patients that are going to have light chain disease, be it myeloma or potentially other things like light chain deposition disease and amyloid, we can detect in the serum. However, it still has a role. It particularly has a role when we're obtaining someone's total protein. That 24-hour urine measurement for protein is particularly important, like an amyloid, where people tend to have massive amounts of proteinuria. So at baseline, when someone has an established plasma cell disorder, be it MGUS, smoldering myeloma, or active myeloma, I always want to obtain the urine at that point, because it can give us further information. And then lastly, there still are a very small subset of patients who have a normal SPEP, have a normal serum-free light chain measurement, but still have light chains in their urine. So as I mentioned, it's not really a good screening tool, but when that suspicion is very high and those others are negative, or once someone has established diagnosis, I would suggest we do the urine testing.
Thank you. Dr. Farnsworth, I'm going to come back over to you. Now, based on your experience with SFLC assays, are there any unanswered questions about this test that are still worthwhile to look into? Say, studies plan to dig deeper into the field?
Yeah, I can't speak to necessarily studies that are currently ongoing, but I do think that there's still a lot of room for us to assess these assays further. So I think we talked at length during my session about the current recommended reference interval or normal ranges. I think we need to really define what those are and figure out what true normal ranges are across populations for various assays. So that includes race, renal dysfunction, and perhaps other things that we haven't discovered yet. So I think that's perhaps a large study that needs to be considered across, again, multiple assays and multiple different platforms. And so I think the same could probably be said of the rule-in threshold of 100. I think that we presented a little bit of data around how it seems to be commutable across various platforms, but it would be really interesting to see, how well that pans true in patients with other diseases, for example, that present with MGUS. Are they more likely to progress at 100, or is there a different threshold for different assays? And again, does that vary based on patients' presenting conditions? It could be really interesting.
Thank you. And we have time for one more question. And Dr. Farnsworth, I'm going to end with you here. It seems like free light chain assays are still not standardized. Is it so? And if so, why not?
Yeah, it's really hard to standardize an assay. I just finished a didactic with our trainees, and we were talking about how do you harmonize and standardize an assay. It's really, really difficult when you have immunoassays with antibodies, some of them polyclonal, some of them monoclonal. You don't necessarily always have the same calibrators. Is there work that can be done to make them more similar? Most likely. But I think even in the study that we showed, it was very surprising to see how close the results were from some of these patients. So in a way, I'm not sure if we'll be able to standardize them or harmonize them much more than they already are, but I don't know if we necessarily need to. It might be as simple as ascribing different reference intervals and thresholds for each. So I think it'll be interesting to see which way the field goes.
Thank you. Dr. Farnsworth, Dr. Mikhael, it's such a pleasure to work with you here and to hear about your important research. Do you have any final comments you'd like to leave for our audience?
I may just say, as I reiterated so often in the talk, but, myeloma is the most disparate cancer within the African American population. And that disparity is multifold, as I said, but we've been focusing on the delayed diagnosis. I can just imagine that there are literally thousands of people in the country now who have brewing myeloma. And if we had a more deliberate way of ensuring that we capture them earlier on, we know their outcomes will be better. And so everyone participates in this, and what we do in the community, in the lay community, what we do in the clinic, and what we do in the lab. And I think that unity together, that work together, is really going to help us reduce that disparity.
Yeah, couldn't agree more. I think for the laboratorians in the audience, we have an opportunity here to really kind of partner with our clinician colleagues as well as patients to increase testing across different patient populations and ensuring that we have the right test for the right patient.
Well, thank you both again for your vital role in the importance of this timely diagnosis. I do want to thank LabRoots for hosting today's event and our sponsor, CBF, for underwriting today's educational webcast. Before we go, I do want to thank our audience for joining us today. There were quite a few questions we were unable to get to due to time constraints. So don't fret, these questions will be answered via the email address you provided at the time of registration. Now, today's webcast can also be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues and your friends who may have missed today's live event. Gentlemen, thank you again for joining us, and to our audience, thank you as well. Until next time, take care, everyone. Bye-bye.
Bye.